Okay, thanks. So we're going to do the same thing with acute kidney injury that we did with acid-base balance, in that what I want to do, again, is I want to provide you a working definition of acute kidney injury. That's going to imply that there are some risks of people developing acute renal failure, so we need to look at some of the relative causes. And then, just as we did with acid-base balance, we're going to develop a practical clinical algorithm for the diagnosis of acute kidney injury. And then we need to recognize a bit of an approach to the rapid treatment of AKI, because the problems that cause acute kidney injury are usually not ones that allow you a lot of time to figure out what's going on before you do something about it. All right. One of the problems that we have had up till now is really a good definition of acute kidney injury. And this is a term that historically we called acute renal failure. And I guess people didn't like that because it involves the term failure, and we don't like our organs to be accused of failing. So this shifted over the last 10 years from acute renal failure to acute kidney injury. Now, I don't like either one of those terms very well, because as you'll see in a moment, the majority of causes of what we call acute kidney injury now really involves no real injury to the kidney at all. And in fact, it involves an appropriate pathophysiologic response to abnormal physiology. And so it's not failure, and it's not an injury either. About 10 years ago, the interest in defining acute renal failure or acute kidney injury resulted in a scheme called the rifle criteria for acute kidney injury. And it involved risk, injury, failure, you get the point, RIFLE. And that was a very good scheme for categorizing renal injury, sudden renal injury, particularly for research purposes. But it wasn't too practical. So a group of experts got together and they modified that definition from the rifle criteria to what this group was called the Acute Kidney Injury Network. And they modified it in such a way that they called it the AKIN, A-K-I-N, criteria. And that was better than the rifle criteria, but again, it wasn't truly a good clinical definition. It was very useful for quantitating renal function for research purposes, but not so much for clinical activity. So last year, a group called the Kidney Disease Improving Global Outcomes, which is an international group of kidney experts, we call them KDIGO, K-D-I-G-O, published in a very important journal, Kidney International, a supplement on acute kidney injury. And in that supplement, they recognized the importance of having an easy clinical definition of AKI, so that when you and I talk about acute kidney injury, we're talking about the same thing. And this is the most recent practical definition of acute kidney injury. That is, an increase in the serum creatinine by 0.3 milligrams per deciliter or greater in 48 hours or less. Or an increase in the serum creatinine of 1.5 times or greater from its baseline over 7 days or less. Or a decrease in the urine volume to less than 0.5 milliliter per kilogram per hour for more than 6 hours. So when we talk about a patient having AKI or ARF, by definition, this is what we're talking about. We're not talking about a volume of urine less than 500 milliliters, so-called oliguria. We're talking about a volume of urine of less than 0.5 milliliters per kilogram per hour for more than 6 hours. All right, so you get the definition here. It's important to recognize the clinical settings in which patients are at particularly high risk for developing acute kidney injury. Probably severe burns is the one clinical setting that has the greatest likelihood of the development of acute kidney injury. And the reasons for this are pretty straightforward. Think about severe burns. What are the processes that conspire to cause acute kidney injury? Well, first of all, you lose an enormous amount of fluid through a burn area. So volume contraction, severe volume contraction associated with severe burns. Severe burns also often involve enormous tissue damage. So you have a lot of tissue damage with the release of intracellular enzymes and proteases and so forth. So of all of the clinical settings that correlate with acute kidney injury, probably the one that has the highest frequency of AKI would be severe burns. And those of you over here on the wards over here, and if you've had nephrology over here, you know that we almost always have one or more consults in the burn unit. Rhabdomyolysis, the massive destruction of muscle tissue that results again in the release of these intracellular enzymes and proteases, also has a reasonably high frequency of the development of acute kidney injury. Aminoglycoside use and the use of other nephrotoxic agents has a relatively high incidence of acute kidney injury. The vast majority of nephrotoxic injuries to the kidney go unrecognized because they're not severe enough to catch anybody's attention. The creatinine goes from 1.0 to 1.5 and nobody notices. But that's acute kidney injury by definition of AKI. Chemotherapy has a relatively high frequency of acute kidney injury, as does open heart surgery of any kind, just being in the ICU. Anywhere around 5 to 25% of patients in the ICU, depending on the clinical series that you review, will develop, by the definitions that I gave you, acute kidney injury. And just being in the hospital portends some risk, and in fact, 3 to 5% of all hospitalized patients on a general medical service will develop, by definition, a decrease in kidney function that qualifies for AKI. So here's the clinical algorithm for AKI. And this is very simple. It's even simpler than the acid-base algorithm that I showed you. Once you've identified a patient with acute kidney injury, you need to know whether the acute kidney injury is of pre-renal origin, renal origin, or post-renal origin. It is always the same. And those of you who've had nephrology recognize that probably 30 to 40% of the consults that you saw were for acute kidney injury, and you always went through the same differential diagnosis. Is it pre-renal? That is there evidence of preserved tubular function? Is it intrinsic renal injury? That is there evidence of lost tubular function? Or is it of post-renal origin? Is there obstruction anywhere along the urogenital tract, from the kidney itself all the way down to the urethral meatus? Again, if you've had nephrology, you recognize these numbers very clearly because they're very typical. when you're asked to see a patient with acute kidney injury, nearly half of them will be pre-renal. So if all you did was say, I've got a patient with acute kidney injury, and I had to wager whether it was renal, pre-renal, or post-renal, I'd always wager pre-renal, because almost half of all of the consults for AKI are related to some pre-renal cause. 20% of them are related to some nephrotoxic renal injury. So 2/3 of all of the cases of AKI that we see are either pre-renal or drug-related. Makes it very simple. About 20% are post-op, and that's usually related to things that happen in the operating room, hypovolemia particularly. About 10% are multifactorial, and these are patients where you never really figure out a single cause, but you can identify multiple reasons why there should be a sudden decrease in renal function. And I show the renovascular number because I want you to remember that very few patients develop acute kidney injury because of loss of blood flow to the kidneys. It's very rare for there to be a renovascular cause. Now, one of the reasons that it's important, not only because making a diagnosis will help you to, by determining the cause of acute kidney injury, to develop strategies for treating the injury or avoiding any further injury, I wanted you to know that in particular patients that have intrinsic renal injury, not pre-renal azotemia and not obstruction, that there's a fairly high hospital mortality that's associated with intrinsic renal injury. For those that develop non-oliguric ATN or non-oliguric AKI, anywhere upwards of 40% die in the hospital. Those that are oliguric or anuric at any time during the course of AKI, they've got almost at least a 50% hospital mortality. So, is it the renal failure that causes the mortality? Not usually. As you all recognize, it's the underlying cause of the renal injury that relates to the mortality. But all of the comorbidities that go along with AKI are the ones that add up, particularly in oliguric intrinsic renal injury, to portend a fairly high mortality. All right, so the basic algorithm, pre-renal, renal, or post-renal. Pre-renal is always characterized by intact tubular function. If you have a patient that's got AKI and is oliguric, you want to determine that tubular function is intact, and when it is, it's almost always caused by a decreased effective circulating fluid volume. So if they're oliguric and they're pre-renal, you need to look for causes of a decreased effective circulating fluid volume. Things like dehydration, things like severe heart failure, things like third space of fluid in patients that have ascites or severe edema. Oliguric patients with pre-renal azotemia will show evidence of intact tubular function. That is, they will show evidence of a concentrated urine. The kidney will be holding on to sodium. And so we look at the urine sodium and the fractional excretion of sodium as excellent markers of tubular function. Unfortunately, tubules can be working completely normally. The patient can have absolutely pure pre-renal azotemia, and their fractional excretion of sodium can be elevated because of the use of loop diuretics. Patients that are getting loop diuretics will have an elevated urine sodium, and so their fractional excretion of sodium will not reflect intrinsic tubular function. So we measure the fractional excretion of urea in addition. All right, so let's talk about these measurements. In oliguria, it is useful to measure the fractional excretion of sodium. What is the fractional excretion of sodium? Fractional excretion. It's the percentage of the sodium excreted in the urine, the sodium that appears in the urine, related to the amount of sodium that is filtered. And it's a percentage, so you multiply it times 100. Well, mathematically, the sodium that is excreted is the clearance of sodium, the renal clearance of sodium. But how do you know what the amount of sodium that's filtered? Well, every ion of sodium in the plasma water is filtered. So the clearance, the sodium that is filtered is exactly equal to the glomerular filtration rate, or the creatinine clearance. So, in fact, the fractional excretion of sodium is the ratio of the clearance of sodium to the clearance of creatinine. It's a percentage, so we multiply it times 100. Well, the clearance of anything in the kidney is the urine concentration times the timed volume divided by the serum concentration. So the clearance of sodium divided by the clearance of creatinine is the urine sodium times the urine volume over time divided by the serum sodium. And the clearance of creatinine is the urine creatinine times the volume per time divided by the serum creatinine. It's a percentage, so you multiply it times 100. But since the volume appears both in the numerator and in the denominator, they cancel out. So you don't need a timed urine. All you need is a spot urine. So the numerator of a numerator stays in the numerator. The numerator of a denominator stays in the denominator. The denominator of a numerator goes into the denominator, and the denominator of a denominator goes into the numerator. You didn't think you were going to have 2 lectures on 7th grade algebra, did you? But that's 7th grade algebra. So the equation simplifies. The fractional excretion of sodium is the urine sodium times the serum creatinine divided by the serum sodium divided by the urine creatinine. It's a percentage, so you multiply it times 100. A simpler way to remember this, if you ever have to calculate it without your iPhone, simple way to remember this, it's the small numbers divided by the large numbers times 100. Nephrology is always simple. So the fractional excretion of sodium of less than 1% tells you that the tubules are working splendidly. And if the patient has AKI and a fractional excretion of sodium of less than 1%, they have a decrease in effective circulating fluid volume that is causing their oliguria and their AKI. Now, remember I told you that sometimes patients are getting loop diuretics, and so the urine sodium will be artifactually elevated because even though the tubules are trying to work, they're being poisoned by furosemide. So we use the same math with the fractional excretion of urea because the filtration and excretion of urea is not affected by loop diuretics. So the calculation is the same, except instead of using the ratio of the clearance of sodium to the ratio of the clearance of creatinine times 100, we use the clearance of urea. The clearance is the same calculation. You see it here. A fractional excretion of urea of less than 35% in an oliguric patient with AKI suggests that tubular function is okay and that they have prerenal azotemia. So, prerenal azotemia is characterized by fractional excretion of sodium of less than 1% or a fractional excretion of urea of less than 35%. Usually a low urine sodium. If the urine sodium is less than 10, I don't need to do any calculations. I don't need the FENA. I don't need the FEUR. If the urine sodium is less than 10, the only way that you can get a urine sodium less than 10 is to have tubular function present. Doesn't matter what the GFR is. It's less than 10. Because what's the sodium concentration of the tubular filtrate, of the glomerular filtrate? It's 140. It's whatever's in the plasma water. And if the kidney can get it down to less than 10, it's prerenal. Prerenal azotemia, though, is also characterized by an increase in the BUN-creatinine ratio. Remember that the BUN-creatinine ratio is usually about 10 to 1. The higher it is away from 10 to 1, the more likely you are to have prerenal azotemia. Remember, you're looking at tubular function. If the urine osmolality is a lot greater than the serum osmolality, then tubular function is present because you're reabsorbing water. The tubule is reabsorbing water. So the urine osmolality, serum osmolality ratio greater than 1.8 or 2 to 1, tubular function is present. Now, what about patients that have AKI and are not oliguric? Well, in patients that are not oliguric, the fractional excretion of sodium and the fractional excretion of urea are less helpful. They're not meaningless. Don't let anybody say, oh, this guy's got good urine output, so the FeNA and the urine sodium are meaningless. They're not meaningless. If the fractional excretion of sodium is low in somebody that has non-oliguric AKI, then the tubules are working. If the fractional excretion of sodium is not low, you don't know. You don't know whether the tubules are working or not if they're not oliguric. But if it's low, tubules are working. In individuals that have non-oliguric prerenal azotemia, they usually have an increase in their BUN-creatinine ratio, so they have a creatinine of 2 and a BUN of 90. It is usually because of an overproduction of waste products, and a production of waste products in excess of their glomerular filtration ability to excrete the waste product. So let me give you an example. So let's say that you've got a patient that's got a creatinine of 0.8 and a BUN of 9, and you give them an enormous protein load. How would you do that? Well, you might give them inappropriate NG feedings with a huge protein load. Or you might give them a big protein load with TPN. Or they might give themselves an enormous protein load through a GI bleed. Okay? Well, when you have a bunch of protein in the gut, you break that protein down, reabsorb the amino acids, they get metabolized to urea. If you've got a GFR of 130, no problem. You'll pee out all that urea, your creatinine will remain 0.8, and your BUN will go to 10. No big deal, nobody notices. But let's say that you've got a creatinine of 2 and a chronic GFR of 40. Your BUN's 18, everything's fine, in equilibrium, but now you have a GI bleed. And you dump this enormous amount of protein into your gut, which you metabolize, but your GFR is incapable of excreting all of that urea that's made from the protein without increasing the blood urea nitrogen concentration. So the creatinine is 2 and the BUN is 90. That's a form of prerenal azotemia because the kidney is doing what it's supposed to do. It's not any further injury, it's not acutely injured, but it can't keep up with the protein excretion. So one of the things that you can do is you can measure the urine urea nitrogen in somebody like this. And you can calculate back, based on the urine urea nitrogen, how much protein it took to make that urine urea nitrogen. Because for every 6.25 grams of protein, there's 1 gram of nitrogen. All right? It's very simple. That 6.25, by the way, is called Sheldall's number. Sheldall It's actually spelled K-J-E-D-A-H-L, Sheldal, was a Danish chemist. And he had a wonderful job. He worked in a brewery. You know, brewing is chemistry. And so he needed to know how much carbohydrate and therefore how much sugar he would get from various grains in the brewing process. And in order to know that, he needed to know how much protein there was in the various grains. So he discovered something very interesting. When he burned down these proteins to figure out how much burned down these grains to figure out how much protein there was in them, he discovered that it didn't matter what grain he was studying, whether it was barley or wheat or corn, they all had 6.25 grams of protein made 1 gram of nitrogen. So we call that Sheldal's number. And you can measure that in the urine and calculate back how much protein they're metabolizing. So if you have a patient whose BUN is out of proportion to their creatinine, and you measure their urine urea nitrogen, and you calculate back that they're metabolizing 200 grams of protein, you know that this is an increased protein problem. When do I see that? Most commonly, I see that in inappropriate TPN, where whoever's writing for the TPN gets the idea, if a little protein is good, a lot will be better. Well, the fact of the matter is you can only incorporate a certain amount of amino acids into new proteins, and you'll metabolize the excess amino acids for calories, and you'll generate urea. So we do that on the wards all the time. Patients that have acute kidney injury and intrinsic AKI will have manifestations of tubular dysfunction. Their fractional excretion of sodium will be greater than 5%. The fractional excretion of urea will usually be close to 40% or greater. Their urine sodium is almost always over 20. Their BUN creatinine ratio is 10 or less. And their urine osmolality, serum osmolality ratio is usually about 1. We call that isosphenuria. Postrenal, very easy to diagnose. It's obstruction, anywhere from the ureteropelvic junction to the urethral meatus. And you can do that with physical exam by feeling the bladder, but we almost always do an ultrasound or a CT scan. Make sure that hydronephrosis is not present. So, since you're really trying to get at, is this prerenal, renal, or postrenal, the initial evaluation of a patient with acute kidney injury involves these findings: a urine sodium, a urine creatinine, a urine osmolality, a urine analysis, a culture and sensitivity to rule out pyelo, and urine for eosinophils to evaluate for allergic interstitial nephritis. We get a renal ultrasound to evaluate for obstruction, and I often, at some time, will get a renal scan to evaluate renal blood flow, especially in somebody that is anuric. Because if they are anuric, making no urine at all, and they have a renal scan that shows no blood flow, I know that they don't have ATN anymore. They have cortical necrosis, and their AKI is permanent. Well, what about the treatment? Here again, the treatment for AKI is to look for the underlying cause and treat the underlying cause, because the things that kill people with AKI are hypoxemia, hypotension, or hyperkalemia, and acidosis. That's why people die. You treat the underlying cause. If they're fluid overloaded, you give them diuretics. If they're dry, you give them fluids. People with AKI are often very sensitive to nephrotoxins, so you avoid all the nephrotoxins. And if they're oliguric, particularly, you want to restrict their potassium, because if they're oliguric, they've got no place to put the potassium. They're going to get hyperkalemic. If they're not oliguric, there's an obligatory loss of potassium in the urine. So patients with AKI that are non-oliguric usually don't develop hyperkalemia. You want to measure their I&O at least for 24 hours. And people that have oliguric, particularly oliguric AKI, need to measure their waste products and electrolytes every day. Well, what about renal replacement therapy? Those of you that have rounded with me know that the 5 reasons for renal replacement therapy are always the same, and they are A, E, I, O, and U. They're the vowels. They're easy to remember. Acidosis, refractory to usual measures. Refractory electrolyte disorders, usually hyperkalemia, but occasionally hypo or hypernatremia. Ingestions with dialyzable toxins. Those are usually small molecules distributed in the plasma water and not highly protein bound. Refractory fluid volume overload. A great deal of attention has been drawn to fluid overload in AKI, and fluid overload in AKI that is not promptly treated portends a much higher mortality than appropriately treated fluid overload. And then, of course, the uremic syndrome, patients that develop uremic pericarditis or uremic bleeding or what have you, they should undergo renal replacement therapy. Now, renal replacement therapy can be continuous or intermittent. There is no evidence that continuous renal replacement therapy is superior in any way to intermittent renal replacement therapies. I tend to use them differently, but I've got no science to that. Low efficiency or high efficiency, defined by high or low blood flow. Again, in people that are hemodynamically unstable, I tend to use low blood flows and continuous treatments. Dialysate flow determines how much waste product or toxin will be removed by diffusion. Diffusion is great for small molecules. It's not great for big molecules. So big molecules need to be removed by convection, so we crank up the ultrafiltration rate. And once you define the duration, the blood flow, the dialysate flow, and the ultrafiltration rate, then I can categorize it as to the renal replacement therapy as to whether it's hemodialysis, sustained low efficiency dialysis, sustained continuous ultrafiltration, continuous veno-venous hemofiltration, continuous veno-venous hemodialysis. This entire alphabet soup that we use to describe renal replacement therapy is defined by the duration, the blood flow, the dialysate flow, and the ultrafiltration rate. And it's much simpler than you're usually presented. Oh, we need to stuff this patient. Or, oh, we need to sled this patient. No, what we need is low efficiency, continuous dialysis. Okay. A couple of last comments about treatment. Low-dose dopamine doesn't work. Okay, the reason that low-dose dopamine doesn't work is because it never gets around to the kidneys. The lung is a hotbed of catechol-O-methyltransferase, COMT. Dopamine and endogenous dopamine is metabolized that way. If you give low-dose dopamine into this vein, it goes first to the heart, then to the lungs. It's all metabolized. None of it gets around to the renal artery. If you drip dopamine into the renal artery of a dog, it causes vasodilatation, diuresis, natriuresis, but clinically that doesn't work. There are some dopamine agonists that are available and some that are in clinical testing that do get around to the kidney, and they may have some promise. Diuretics have no influence on the outcome of oliguric AKI. Now, what I will do in somebody that's got oliguric AKI is I will usually give them 1 or 2 large doses of diuretic right at the very beginning, if they're not volume contracted. If they're volume overloaded, I'll give them a couple of doses of diuretics, and I don't mess around with small doses. I don't start with 20 of Lasix, and then 2 hours later give them 40, and then 2 hours later give them 60, and then 2 hours later give them 80, because if the volume management of fluid overload in AKI is important, it's important in the first few hours. So what I'll do if I'm going to try to use diuretics to volume manage them, I'll give them 4 milligrams of Bumex right now. If that doesn't work, they're not responsive to diuretics. If you're going to use Lasix, give them 200 milligrams of Lasix right now. If it doesn't work, they're not going to respond. You need to know the patient's volume status. Remember, I told you that fluid volume overload is an important comorbidity to mortality in AKI. And don't overload patients with AKI with protein. There's no evidence that using protein replacement solutions is any better than sodium chloride or sodium bicarbonate. Above all, patients with AKI, do whatever you have to keep them alive. If you can't correct the underlying problem, renal function will not recover. If you can correct the underlying problem, then you have a much greater likelihood of renal recovery. Age and comorbidities do influence survival and recovery, but there are no goner factors. When I was a fellow, we did an enormous study of patients with acute renal failure looking for comorbidities that always portended mortality. So, we have this oliguric acute renal failure that may have a 50% mortality in the hospital. We wanted to know if there were factors that you could put together and say, oh, if they've got 90% burns and hypotension and rhabdo, they all die. Well, guess what? They don't all die. So the fact is that there are no goner factors. Patients, even with the most severe underlying comorbidities causing acute kidney injury, can still survive. And that's why we are usually very aggressive about renal replacement therapy in even patients that have multiple comorbidities and AKI. So, AKI is an abrupt decline in kidney function that results in increased waste products. We defined AKI according to the KDIGO guidelines. There are potentially life-threatening complications that include volume, hyperkalemia, acidosis, and uremic complications. These are the things that kill people with AKI. And finally, volume status should be assessed and corrected, and you shouldn't use diuretics to correct volume overload. If they don't work right away, you should not use them. You should use renal replacement therapy because although volume is an important predictor of outcome, correcting fluid volume overload quickly and early in the course of AKI has the greatest effect on survival. Okay, let's